A very good evening to all the respected dignitaries, seniors, colleagues, experts, speakers, and all the attendees who have joined us through Zoom as well as live YouTube channel. Welcome you all on behalf of MahaIP and MahaIP Women's Committee for today's program of Tuesday Day. This unique program was designed and was a huge success last year. So we continued it this year too in 2023 with a difference. We have 5 speakers from different zones of Maharashtra allotted with 5 different topics, 8 minutes for each speaker to present, and we have 1 expert for guidance who will give his expert opinion after each topic. Viewers, please note today's program has been allotted 1 MMC point, so requesting everyone to please type your name, city name, central IIP number, and MMC registration number in the chat box. Dr. Shirish Dattare Deshpande sir, Senior Physician from Nasik, is the MMC observer for today's program. I, Dr. Neha Singh, MahaIP Women's Committee co-chairperson and practicing pediatrician from Navi Mumbai, Raigad district, as well as my co-host Dr. Sonal Shinde, zonal member of MahaIP Women's Committee from North Maharashtra, from Ahmednagar, are the moderators for today's Tuesday Day. Now I welcome and request our MahaIP President, Dr. Ramakant Patil sir, to please give his blessings. Over to you, sir.
Thank you, Neha. I really congratulate Dr. Sonali Shirbate, Chairman of Women's Committee, MahaIP 2023, and co-chair Dr. Neha, ever smiling and taskmaster, and she does every work which is being allotted to us with flying colors. So Neha, thank you for making this Tuesday Take the episode again in reality. I also wish all the best to today's speaker, Dr. Sheetal Kole, Dr. Ujwala, Dr. Anurag, my dear friend, and who is very excellent in his diction, and he is really master in ECD training. So welcome, Dr. Anurag, Dr. Rushikesh Ghator, and Dr. Amol Mahajan. And my colleague in BJMC, we were co-house residents. In fact, I was a 2 years senior to Suchit Tambule. I am really proud to see that he is today's expert. So he has traveled miles ahead of me in academics. So really pleasant occasion for me. Welcome, Suchit.
Thank you.
And so many who's who of MahaIP are present over here in the delegates. Dr. Immediate past president, Dr. Hemant Gangulia ji is there. Dr. Uday P was Mumbai IIP president, who is also seen over here. So I will not like to take much of the time, and really wonderful topics are being selected by this Women's Committee, particularly Dr. Sonali Shirbate, Neha Singh, today's in charge again, Dr. Sonal Shinde, and all the regional Women's Committee, and they are ably being guided in last year and this year also by my CIPEB colleague, Dr. Renu Boralkar. So thank you, Amol, and all the team. And Suchit will enlighten us after every talk of every speaker. And I appeal all to limit to your time schedule of 8 minutes. So last time it had been extended for quite a long. So more and more people should have continued interest into this. So thank you for giving me an opportunity and have listening quite patiently. So I didn't take name of all the Women's Committee members, but I'm really impressed with your activity. Dr. Manjushri Sherkar Madam, Dr. Sonali is already there. Shilpa Dudgavkar didn't join it, but all are working very steadfastly. Thank you.
Thank you, sir, for your blessings. Now I request our MahaIP Secretary General, Dr. Amol Pawar sir, to kindly say a few words. Over to you, sir.
Thank you, Neha. It has been a journey of almost 11, and this 2 episodes. This is, I think, 13th episode since last February. So many young speakers got chance to showcase their talent and their academics over MahaIP platform. Already Dr. Ramakant Patil sir has told all the things. Straight away, I asked Dr. Neha to continue the session further, and I welcome Dr. Suchit Tambuli sir, Anurag sir, and all the stalwarts of Maharashtra IIP and young generation and all the delegates who have joined to learn academics and to get one MMC point also. And I also welcome Dr. Shirish Deshpande sir, senior physician, who is the MMC observer. He is busy right now, but he has joined. So I appeal all the delegates to be there throughout the session to get one MMC point and to enter their details in the chat box. Thank you. Over to you, Nia.
Thank you, Amol sir. I welcome Dr. Sonali Shirbati ma'am, our MahaAP Women's Committee chairperson, to say a few words. Over to you, ma'am.
Thank you, Dr. Neha. On the second session of Tuesday Tech, I welcome respected President Dr. Ramakant Patil sir, Honorable Secretary General Dr. Amol Pawar sir, IPP Dr. Gangulia sir, and Dr. Suchit Tamboli sir to this platform, as well as all the respected dignitaries of Central IIP, OBs and EBs of MahaIIP. I welcome all. Please don't forget to write your question in the chat box. We will try to solve the query. Not taking much time, let us proceed. Thank you, Dr. Neha.
Thank you, Sonali ma'am. Do we have our MMC observer? He has connected.
He is
Dr.
busy.
Shirish?
He has joined, but he is busy right now.
Okay.
We'll continue.
Okay. Now our first expert, our expert for today is Dr. Suchit Tamboli sir. He is PhD in Developmental Pediatrics, FIAP, Fellowship of Indian Academy of Pediatrics, MBBS, DCH, PG, DAP, PG, DMLS. First practicing pediatrician in Maharashtra to be honored PhD from MUHS, awarded as India's top most 25 pediatrician and most promising doctor in developmental and adolescent pediatrics in India, National Executive Board member of Central IIP 2017-19, faculty in international, national and state conference since 1999, and he has given more than 350 lectures. He is director of NABH Pre-Aggregated Hospital Center, National Coordinator of IIP Action Plan, Basic of Behavior Module, National Convener and Coordinator Development for All Cradle to Crayons Easy Intervention, Early Intervention, Chairperson of Government of Maharashtra Disability Certificate Committee 2015, ex-National Chairperson IIP, GDVP chapter since 2014-15, Organizing Committee member and World Pediatric Congress Singapore 2023. He has edited editor of 3 books and indexed 15 papers in journal. Now I request Dr. Suchit Tamboli sir for to give his few words.
Thank you, Neha, for this introduction. And I think today's topics are very good topics. They are very practically oriented and not taking much time. I think we should start immediately because all speakers have prepared very well, and we are very eager to listen to them. And then after every lecture, I will give a few remarks. But we must start immediately.
Yes,
And all speakers are very good. And I first congratulate Dr. R.D. Patil and Amol Pawar for this very good program. And Dr. Sonali, Neha and Manjusha, you are doing very good work. And I wish best for this Tuesday talk.
Thank you, Suchit sir. We also acknowledge the presence of past President Dr. Hemant Gangulia sir and past Women's Committee Chairperson Dr. Renu Boralkar ma'am. Now I hand over to Dr. Sonal Sinde for further proceedings. Over to you, Dr. Sonal.
Good evening, all. First of all, I thank Team MahaIIP for giving me this opportunity to be a part of this auspicious group. We'll start with the presentations now. First speaker is Dr. Sheetal Kohli ma'am. Ma'am is a member of Navi Mumbai IIP. She will be presenting the case care of newborn baby. Ma'am is NICU in charge and professor at D.Y. Patil Hospital, Nerul, Navi Mumbai. She is a national NRP trainer and Mayo certified simulation instructor. She is in charge of Atulya Amrut Human Milk Bank. Ma'am, over to you.
Thank you, ma'am, for wonderful introduction. Now, good evening, all dignitaries on dais and all participants.
Yes.
So, today's topic is care of normal neonate. Normal neonate is baby with birth weight of more than 2.5 kg, term baby who didn't require any resuscitation at the time of birth, who doesn't have any untoward intrapartum or postpartum events which led to an ICU admission. So, what are components of normal born care is beginning from the birth, that is preparedness before delivery till the discharge. That is what we are going to see in today's presentation. So, when what care we have to offer at birth, that is place, person and equipment. How many people are going to attend the delivery depending upon the intrapartum risk and antepartum risk factors we are going to decide. Then place of the delivery has to be prepared earlier. So proper dedicated newborn corner in a delivery room with radiant heat warmer and all neonatal resuscitation equipments has to be ready, and we have to follow 5 C's for the delivery, that is clean hands, clean surface, clean blade, clean cord and clean tie. So immediately after birth we have to establish temperature, airway, breathing, circulation. Out of that, T, temperature, is extremely important. Provision of warmth to prevent hypothermia is one of the cardinal principles of newborn care, and that we have to take care of. So we have to maintain warm chain from birth in even in the postnatal care also. So warm delivery room, warm resuscitation, immediate drying of a newborn, skin to skin contact we have to establish within 10 minutes, breastfeeding as early as possible within 1 hour, bathing and weighing has to be postponed, appropriate clothing including cap, mother and baby together, rooming and bedding in, bomb transportation, and more training awareness session for the healthcare provider. That is what is required. So babies who are having temperature less than 36.5 degrees centigrade are considered as hypothermic, and severe hypothermia is less than 32. So we have to manage baby in cold stress when the temperature is between 36 to 36.5. Now, once the baby is born, nowadays delayed cord clamping by 1 to 3 minutes in a stable baby is crucial, and that stump has to free of antiseptics. We have to show gender to the mother and other relatives, and we have to put identification tag on baby's hand, and we have to take footprint on neonatal record sheet as well as mother record sheet. Cleaning of all infants with the sterile cotton, but no attempt to remove vernix from the body because it is protective. We have to establish good skin to skin contact within 10 minutes and initiate breastfeeding as early as possible in any position comfortable for mother and baby. And we have to weigh the baby once euthermia and breastfeeding is established with a weighing scale of 5 gram sensitivity, administer vitamin K, and plan for immunization, that is BCG, OPP and hepatitis B. Rooming in and bedding in has to be practiced because in initial couple of hours after birth, infants are awake, very active. So that has to be utilized for bonding and initiation of breastfeeding. Now, clinical screening for malformation like bilateral choanal atresia, esophageal atresia, anal atresia, and other abnormalities has to be detected at the time of birth. We have to identify sick neonate, extreme premature babies, low birth weight babies with congenital anomalies, asphyxiated with respiratory distress, and those has to be admitted in the neonatal ICU care unit. Then what is concept of golden hour? In first hour of life is golden hour of baby's life, where we have to maintain euthermia, we have to initiate breastfeeding, vitamin K, and admission procedure has to be completed. Now, what we have to offer in postnatal care? So in postnatal care, baby should be observed in the postnatal ward at least 2 times in a day, and emphasis has to be there on temperature maintenance, exclusive breastfeeding. Then we have to offer cord eye care, weight, jaundice evaluation, other screening, and counseling of mother and family that we'll see subsequently. So exclusive breastfeeding, initiate breastfeeding within half an hour to 1 hour and give exclusive breastfeeding for 6 months. And when the baby is born, highly concentrated sticky fluid with rich anti-infective properties, that is colostrum, considered as first immunization, must be fed to the baby. We have to practice demand feeding day and night, and we have to one breast at a time with interactive feeding. Talk to your baby when baby is alert, and do not give prelactal feeds. Then when we start breastfeeding, mother and baby has to be in comfortable position. We have to explain mother position. We have to put the baby in proper straight, whole body supported, with good skin to skin contact between mother and baby's tummy, with proper attachment, good attachment on the breast, that is wide open mouth, chin touching the breast, lower lip curled outside, and more areola visible from above and below. So when we are not able to establish good attachment, then mother can develop sore nipple, thereby breast engorgement, poor milk supply to the baby, and poor weight gain. So failure of lactation can happen. So we have to emphasize on mother position, baby position, and good attachment on the breast. Now for mental development in initial phase, is all mothers should be counseled about mental health by multimodal stimulation in initial stages, and asked to do interactive feeding, talk to your baby when they are alert, play with rattles, use of hanging toys, music therapy, listen music with distance of more 0.5 and at least 3 hours daily. That is what is required for baby's development. For cord care, cord has to be clamped properly. You should not use any antiseptic for the cord. Eye has to be cleaned with the sterile swab with either normal saline or sterile water. From medial to lateral canthus, bathing has to be avoided in the hospital. Sponging can be encouraged. Then oil application, yes, we can use. Now, few myths about this, like traditional practices of putting kajal, surma, oil in the ears, then frequent cleaning of trunk, massage milk expression from the baby's breast should be discouraged. Avoid using powder baby cream, turmeric, avoid heat fermentation, then avoid stretching the hands, legs for wrapping the baby. So that has to be discouraged. Babies has to be weighed in the postnatal wards. And you have to explain parents that term baby for 5 to 7% weight loss in first 7 days, and preterm baby 10% weight loss in first 10 to 14 days is acceptable. They will regain this weight once the breastfeeding is properly established, and tell them that term baby adequate weight gain is 30 gram per day and preterm is 15 gram per kg per day. So that has to be explained to the parents. Now, regurgitation, vomiting is common after birth because of faulty technique and aerophagia. Burping can be advised, and if it is persistent projectile or bile stain, that babies need evaluation. Excessive crying because of hunger and discomfort is acceptable. You have to sort it out. But if persistent crying is there, then examination, detailed evaluation is required. Now, stool pattern. So baby has to pass meconium in first 24 hours. Baby passes transitional stool in 3 to 4 days. Yellow sticky stools are there. And if the baby is comfortable and adequate weight gain is there, then 8 to 10 times stool passage in a day or once in 3-4 days, both patterns are acceptable. Now, danger signs, that difficulty in feeding, poor feeding, convulsion, lethargy, fast breathing, chest indrawing, hypohyperthermia, bleeding, then excessive crying, then respiratory difficulty has to be, you have to see them carefully in the PNC ward. Evaluation of jaundice and congenital heart disease. You have to do visual assessment in daylight by Kramer staging, and when they are in zone 5, that is when bilirubin is more than 15 milligram per deciliter, then they need further evaluation. very important thing, all 4 limb saturation and auscultation for murmur of each and every postnatal baby for evaluation of congenital heart disease is important. Then there are certain variations like Mongolian spots, milia, white dots on the nose, Ipstein pearl on the hard palate, then peeling of the skin, subconjunctival hemorrhage, vaginal bleed. These are normal variation which has to, in this condition, counseling and reassurance to the parents is required. Erythema toxicum is also common entity which happens within 2-3 days and disappears in another 4-5 days. So that also has counseling and reassurance is required. There are conditions like all these mastitis, neonatal, umbilical hernia, tongue tie. These are there. So there you have to counsel the parents and make them aware. Now, when baby should be discharged? Ideally, infant should be discharged within 3 to 4 days, are free from illnesses, no jaundice, fully immunized, adequacy of breastfeeding is established, they are comfortable and screened for congenital heart disease, auditory evaluation and normal newborn screening test has to be sent. Then every mother should get ample opportunity to ask questions and clarify her doubt and major weight at discharge. On discharge, you have to tell them about the importance of breastfeeding and how exclusive breastfeeding will help them regarding immunization, follow-up, and danger signs, that is difficulty in feeding, convulsion, lethargy, fast breathing, severe chest indrawing, and yellowish discoloration of palms and sole, that you have to make them aware. On follow-up, each baby should be followed up for the development assessment of the growth, early diagnosis and management of illnesses, health education of the parents. It is preferable that every baby is seen and assessed by a health worker at each immunization visit. The development assessment should be organized both in and sleep. Thank you so much.
Thank you. Thank you, Sheetal Kole, madam. You have explained normal baby care very nicely. And I think I will just add a few things that for the best breastfeeding, what mother should do from the birth is that she should eat 4 times a day with extra breakfast. She should eat all type of food, whatever she likes, but it should be homemade. And the third thing is that she should take full rest. And nowadays, government has given 6 months breastfeeding leave, and that should be insist. And for that breastfeeding leave, she should actually be with her mother, so that she will get very relaxed mood, and that is definitely will be helpful for getting more weight. So I think that is again one important point is that she should take care of the baby with the relaxed mood. That is very important. काळजी घेणं आणि काळजी करणं याच्यातला फरक त्यांना समजून सांगितला पाहिजे, आणि तो जर सांगितला तर खूप चांगला फरक पडतो, आणि या 4 गोष्टी अतिशय महत्त्वाच्या असतात. तर after that, I want to give one comment regarding the cry, that mother should start identifying the various different cries. Hunger cry, or baby is in the pain, or many times they complain that while my child is passing urine, baby is crying, or my child. So actually what happens that while passing urine also baby cries, and after a few seconds she gives indication that you should change the diaper. So again baby will cry. So that indications should be taken care of, and what is the cry, and what so where you should not use any medicine, that is very important. So for normal babies, use minimum medicine.
Yes,
and
sir.
give proper care. Thank you very much.
Thank you, sir.
Thank you, Sheetal ma'am, for this brief lecture regarding normal care of newborn baby. And thank you, Tamboli sir, for your expert comments. Now, I would like to welcome our next speaker, who is Dr. Ujwala Sirsat ma'am, member of Ahmednagar IIP. She will be presenting topic of breath holding spells. Madam is working as assistant professor at Vikhe Patil Medical College, Ahmednagar.
and is certified in pediatric nutrition and basics of COVID and pediatric COVID. Recently, she was a part of management team of emergency in Shirdi, which consisted of up to 240 students from Amravati district. Over to you, ma'am.
Thank you. Good evening to all seniors and Maha IPN. Thank you for this wonderful opportunity and being the part of this wonderful academic session. Today, my topic is breath holding spell. So breath holding spells are the brief periods when the young children stop breathing for up to 1 minute. We know that these spells often cause child to pass out. That is the loss of consciousness. Breath holding spells usually occurs when a young child is angry, frustrated, in pain, or afraid. But these spells is a reflex. The children don't have breath holding spell without purpose. So the breath holding spells, there are two types. Cyanotic spells, which is caused by change in the child's usual breathing pattern, usually in response to feeling angry or frustrated. It's the most common type. Then the pallid spells. The pallid spells is caused by slowing of the child's heart rate, usually in response to the pain. And the percentage of cyanotic spells is almost 62%, pallid spells is 24%, and mixed types are 19 to 24%. It occurs between 6 to 18 months of age, affect mostly 4 to 5% of the pediatric population. These are spontaneously disappear by 5 years of age, and male to female ratio is 3:1. And cyanotic spell or pallid spell, they are having positive family history in 20 to 30% of the patient. The autosomal dominant with reduced penetrance is the inheritance mode. So what are the breath holding spell? Some spell maybe we have seen both types. Breath holding spells can occur 6 years also, but the most common is 1 to 2 years. Some children may have them every day, and some may have only once in a while. The breath holding spell are usually not serious and don't cause any lasting long time cerebral damage. With time, they go away on their own. So coming to the next point, what are the symptoms? Breath holding spells may cause fainting, then the twitching, then stiff body or seizures. Then what are the symptoms? These symptoms are cyanotic spell. We should look after whether it is cyanotic or acyanotic for the management purpose. The child may breathe too fast in cyanotic spell, and in cyanotic spell, there may be long pause before the child takes another breath. While in pallid spells, the heartbeat may slow down, which is seen in pallid spell. The skin may turn red or blue in color, especially around the lips while we observe the cyanotic spell. The skin may be pale and sweaty while baby is crying, is pallid spell. Then there may be short burst of intense crying in cyanotic spell, and in pallid spell, there may be single cry or no cry at all. So what is exactly etiopathogenesis in between? The slide I couldn't display here, but I can explain that the main cause of cyanotic or pallid spell is autonomic dysregulation, which is playing the vital role in this breath holding spell. We'll see about the etiopathogenesis about cyanotic spell. It is mainly because of the sympathetic overactivity, which lead to the inhibition of the respiratory efforts and the abnormalities of the pulmonary reflexes, which will lead to the VQ mismatch, and that will depend upon the cyanotic spell. While in the pallid spell will be due to parasympathetic overactivity. It may lead to the bradycardia. Then there will be the transient asystole, and it will lead to the pallid spell. This is the etiopathogenesis mostly because of autonomic dysregulation. And mostly the breath holding spells are due to the disturbed parent and child relationship. Mostly such parents are very overprotective and oversolicitous. As most attacks are precipitated by the emotional factors such as anger, fear, frustration, it is possible that many children use it manipulative devices. So what causes breath holding spell? Breath holding spells we have seen about the etiopathogenesis, but what happens while spells are there? In response to the respiratory inhibition, the child usually emits short and loud cry will be there, which leads to the sudden involuntary holding of the muscles or breath in forced expiration. Because of that, the child becomes sinus rapidly and faster than the anticipated with the simple breath holding. And the child becomes rigid and limp, followed by the transient loss of consciousness. Rarely the child may throw seizures if apnea is prolonged. These are the some etiopathogenesis or hypothesis has been mentioned. So in some children, the breath holding spells may be related to the iron deficiency anemia also. How to diagnose? There is actually there is no any lab test which we can have for the diagnosis. The diagnosis depends only on the good and detailed clinical history, which is very important, describing the entire episodes as and when it occurs. It must also include precipitating events like emotional stimuli or trauma, then the presence of urinary incontinence, uprolling of eyes, and deviation of the mouth are commonly seen with the seizures, especially if not preceded by the cry. So we need to differentiate whether it is in diagnosis, the complete physical examination, including growth and development, is essentially, especially the cardiovascular examination or for the rhythm disturbances, and no imaging or specific lab investigations are necessary. So coming to the differential diagnosis. In differential diagnosis, mainly, we can see that there are common causes like manifestations of the obstructive sleep apnea, parosmia, sleep-related laryngospasm, then gastroesophageal reflexes, frontal lobe epilepsy. Apneic episodes may occur in the neonatal group because of the sepsis. What are the differential about the pallid spells? Like seizure activity with the autonomic symptoms, vasovagal syncopes, cardiac arrhythmias, prolonged QT syndrome, hypothermia, and familial dysautonomia. So how to differentiate between the seizure activity and the breath holding spell? So in seizure activity, it can happen in the all ages, where the breath holding spell, they are mostly seen in infant and the toddlers. Familial causes often in seizures and breath holding spell. Provoking stimulants are absent in the seizure while it is present in the breath holding spells. In sleep relation, mostly it is seen in the seizure activity where it is never occurred in the breath holding spell. The stereotype episodes are usually seen with the seizures, and the breath holding spells, it is always seen stereotype episodes. And the post-ictal changes are seen in seizures while the breath holding spells, it is unfair. And the EEG may be abnormal in the seizure activity, while the breath holding spell EEG will be the normal. These are the some differentiating points between the seizure and the breath holding spells. So coming to the management, the first key to the management of BHS is including educating the parents how to intercede before the episode progresses and the child become distressed. The parents should help with children internalize the control they want their children to exhibit. It involves mainly the two parts, demystification and the reassurance to the parents. So a complete physical examination includes growth and development is essential regarding the cardiovascular examination also for the rhythm disturbance. No imaging, no specific lab investigation is necessary for diagnosis. We already mentioned about the iron supplementation. The recommended dose is 4 to 6 mg per kg only for 3 months. So what is the exact pharmacotherapy? There is no any drug which is proven till date is cured for the breath holding spell. Iron supplementation already we mentioned, but nowadays paracetamol is cyclical derivative of gamma aminobutyric acid has been effective as prophylaxis 40 mg per kg per day in children with severe and repeated BHS. But the point is again controversial. The many children with the prolonged asystole associated with the frequent and severe pallid spells have been treated with the atropine to antagonize the vagal hyperactivity. The refractory cases need cardiac placing, but these are all hypothetical and it to prove again. So we should always reassure the parents what they should do during the breath holding spell. Firstly, we should tell them, stay calm, lay your child on their side and watch over them until the spell ends. Don't put anything in child's mouth, not even your fingers to clear the air. Don't shake your baby or child. This is very important points which baby or a baby's mother can do by herself. Then when we should call to the doctors, this is again emergency if mother feels. So how we will differentiate all this? When they should call us? Age less than 6 months of old, then pass out time is more than 2 minutes by clock and normal breathing now. Your child looks or acts very sick, then the first breath holding spell. If you think your child need to be seen by doctors and problem is urgent. Contact doctor during the office hours if never been checked by the doctors for the spell. The spells happen without reason or no triggers. Picky eaters, especially for meats, then the muscle jerks during the spells. Lots of tantrum triggers the spell, and if spell happens more than once a week. These are the some we can give guidelines or we can reassure the parents when they should call us. Not in for every breath holding spell they should call us. So thank you Maha IAP for giving me this wonderful opportunity to present my topic.
Yes.
Thank you.
Thank you very much. You have presented very nicely, and
Thank
I think only a few comments I just want to make. That most important is that assurance to the parents.
Yes,
And you must give assurance that I have not seen a single death due to breath holding. That is very important sentence that will definitely assure your parents, because they are very worried about death due to breath holding spell, and they may express it or not express it, but they have that worry in their mind. So that should be told to them whenever breath holding spell patient comes to you. And one thing is that whatever the things is regarding that, if anything baby wants, that maybe toy or maybe something, some activity. So if it is possible to give them, you give it immediately. If it is not possible to give, refuse it and be firm on that, so that when child will know that after crying for few seconds or few minutes, you will get that thing. So that then they will, whenever they accept it, की देण्यासारखं असेल, करण्यासारखं असेल, लगेच मिळेल, नाही म्हणजे ते नाहीच मिळणार. So that is very important. So if you assure them that whatever you want, you will get it immediately, and if it is not to be given, you will not get it at all due to your cry or due to your breath holding. That is very important. And then actually even you can keep that child in another room if the persistent. Child will not have any, but child will know that I will not get the things properly. So that actually overcoming his own emotions or stubbornness is very important in managing breath holding spell also. Thank you very much.
Thank you. Thank you, sir.
Thank you, Ujwala ma'am, for your presentation. Thank you, Tamboli sir, for your expert comments. Now I would like to welcome our next speaker, Dr. Anurag Pangrikar sir. Sir will be presenting today on the special topic, that is disorders of sexual development. Sir is a member of BEAD IAP. Sir is a gold medalist in MD Pediatrics and is also a law graduate. So his areas of interest are medical, legal and nutrition. Sir has received 3 national and 2 state awards. He is a EB member of Maharashtra IAP 2023. He is ex-president IAP BEAD. Recently I had an opportunity to meet him when he had conducted an ECD workshop in Ahmednagar. Welcome, sir. Please begin with your presentation, sir.
Thank you so much for so nice introduction. This is 8-minute talk, so seedhi baat, no bakwas. Thank you, Maha IAP. The topic allotted to me was ambiguous genitalia, but nowadays ambiguous genitalia word is not used. The word used is disorders of sexual development. This is proposed by consensus statement on management of intersex disorders 2006. So DSD is defined as congenital condition in which development of chromosomal, gonadal or anatomical sex is atypical, and the prevalence is 1 in 4,500 births. Prevalence may be more, but many cases are underreported. So the revised nomenclature by this consensus group is 46XY-DSD, 46XX-DSD, ootesticular DSD, and so on, as per given in this chart. The revised classification says sex chromosome DSD, 46XY-DSD, and 46XX-DSD, and with their etiologies, they can be further subclassified. We will directly go to the various events resulting in various malformations in developing these gonads. So up to 6 weeks, the bipotential gonad is there. In presence of SRY gene on Y chromosome, testes get developed. Then Sertoli cells secrete anti-Mullerian hormone, which causes Mullerian duct regression, while Leydig cells of testes form testosterone, which causes epididymis, vas deferens, and seminal vesicle from Wolffian ducts, and dihydrotestosterone forming creates penis and scrotum. If SRY gene is not present, the ovaries develop as estrogen is formed because no AMH. Mullerian ducts develop and result in forming of fallopian tubes, uterus, upper vagina. As testosterone is not there, Wolffian ducts regress and lower clitoris and labia. This is all going on inside. And we can see pictorially the undifferentiated gonads in upper picture, and left side is male and right side is female, how it develops under various hormones. And similarly, at the same time, the external genitalia, which are seen at 4 to 6 weeks in upper figure, left side is male, right side is female. So sexual organs develop in 3rd to 4th month, and at time of birth, we can see in these pictures. So what is normal male genitalia? It is the stretched penile length has to be more than 2.5 centimeter. External urethral opening should be at the tip of penis. Scrotum is relatively larger, having darker skin, and both testes in scrotum. And normal external genitalia in a female child shows labia minora and clitoris are completely covered by labia majora. Skin of labia majora is darker. Mucoid, occasionally bleeding, these are discharges seen. Prader classification shows leftmost normal female and rightmost is normal male genitalia. And in between are 1, 2, 3, 4 grades of DSDs. So when to suspect? If with a penis, non-palpable bilateral testes, unilateral cryptorchidism with hypospadias, penoscrotal or perineoscrotal hypospadias with or without microphallus, even if the testes are descended, apparently female appearance with enlarged clitoris or inguinal hernia, overtly abnormal genital developments such as cloacal extrophy, symmetry of labioscrotal folds with or without cryptorchidism, discordance of external genitalia with prenatal karyotype done. These DSDs usually are diagnosed at birth, but many times they present late in children and young adults. They can present like an inguinal hernia in a girl, incomplete or delayed puberty, virilization in a girl, primary amenorrhea, breast development in a boy, gross and occasionally cyclical hematuria in a boy, and a previously unrecognized genital ambiguity. During history taking in such patients, we should ask for maternal exposure to androgens, maternal virilization, maybe because of placental deficiency of placental aromatase or luteomas of pregnancy, ingestion of exogenous hormones like oral contraceptives, consanguinity among partners. In family history, urologic abnormalities, precocious puberty, amenorrhea, infertility, neonatal death. History of previous neonatal death may be a clue towards CAH, siblings with primary amenorrhea, or XY karyotype seen in patients with X-linked androgen insensitivity syndromes. In physical examination, my important message is inspection and palpation of genitalia of every newborn is must. Not only inspection, palpation is also must, because many times you can see gonads in the labia in females. Testicles should be palpated in frog-like position during its course of deep inguinal ring, superficial inguinal ring up to scrotum. Documentation of size of penis or clitoris, number of perineal openings, and presence of testes in labia or inguinal region should be considered. In male, stretched penile length should be seen. Usually it is 2.8 to 4.2 centimeter, but it can be less in preterm babies as well as in pueres. Only microphallus is not a marker of disorder of sexual development, but microphallus with non-palpable testes, scrotal or perineal hypospadias, or hypospadias with unpalpable gonad are clues in male. In female, if clitoromegaly is there, that means clitoris more than 9 millimeter. Other findings include fused labial folds, inguinal masses, urogenital sinus formation. Other features, dysmorphic features other than genital should be documented, like microcephaly, posteriorly rotated low set ears, fusions of second and third toes, short broad neck, widely spaced nipple, aniridia. Now the question comes, what to tell to parents at birth? We should remember that this requires a team of doctors involving pediatrician, pediatric endocrinologist, urologist, plastic surgeon, medical geneticist, psychologist. And while explaining to the parents, show the baby to the two parents, counsel both parents together. And what to tell to these parents? Tell that this baby is healthy, but the external genitalia is incompletely developed and we need to do few tests to determine the sex. Don't be in hurry to comment any sex. There are other babies with similar condition. Number of treatable conditions can result in atypical. These are all counseling points which we should tell to parents. Reassurance that a good outcome can be considered. And these investigations may take 3 to 4 weeks. And fertility is many times possible that we have to explain to these parents. Specific molecular diagnosis is identified only in 20% of cases of DSD, but majority virilized 46XX infants will be CAH. In contrast, only few 46XY children with DSD will receive a definitive diagnosis. Diagnostic evaluation includes karyotyping, X and Y specific probes with SRY gene, imaging like sonography, MRI, measuring 17-hydroxyprogesterone, various hormones. These investigations usually are available around 48 hours, so may comment something. Algorithms are available for diagnosis. It is not in purview of this 8-minute talk. HCG, ACTH stimulation test, urinary steroids, imaging, gonad biopsy, gene analysis are the investigation. How to manage? The first question is gender assignment. Surgical management, whether early or late around puberty. Possible malignancy in gonads to be considered. So few DSDs required removal of gonads, sex steroid replacement for the life, psychological management. Gender assessment of newborn is very, very stressful for these families. The factors that influence are the diagnosis, genital appearance, surgical options, long replacement therapy. We have to comment regarding potential for fertility, and sometimes the circumstances relating to cultural practices are to be considered. Usually 46XYCH, XXCH is assigned as female. And I cannot stop my talk without these 2 slides on congenital adrenal hyperplasia, because defect in one of the enzymes involved in cortisol, resulting decrease in cortisol, resulting in increased ACTH and other steroid hormones, 90% due to 21-hydroxylase deficiency. Other 3 hormones are given in the slide. And there are 3 types. It is an emergency. We should never miss, though the child appears normal at birth, but later on, 75% children are salt wasters. They present in shock-like stage. Some are only virilized, simple virilizer in around 25% of patients. And there are some non-classic variations. So thank you. Sorry that I have exceeded 1 minute 50 seconds. Thank you.
Thank you very much, Anurag. I think you have explained it very nicely. And it is very important that counseling part is very important, because parents are very worried about that and they want immediate sex to be told. But we should be patient regarding such cases, and at least 1 week, what he has suggested is very good time, that you should take that time and actually get all investigations done, and then only you should comment. That is very important point. I think as he has explained very nicely, none other than these comments I want to done.
Thank you. Thank you.
Thank you, Anurag Pangrikar sir and Suchit Sambori sir. Now I welcome our next speaker, Dr. Rishikesh Ghator. He is a member of Amravati IAP. He will be presenting today developmental history of a child. Sir works as developmental and behavioral pediatrician at Prayas Child Developmental Center, Amravati. He has done fellowship in developmental neurology and learning disability and neurodevelopment. Over to you, sir.
Yes, am I audible, ma'am?
Yes, sir, but
yes.
Yeah, okay.
Full screen.
Just
full
make
screen. Sir.
full
Full
screen.
screen.
Just give me a minute, please. Yes.
It has
Is it okay now?
no. Rishikesh full screen कर.
Yes, yes, केला है सर. केला है.
नाही दिसत आहे.
नाही दिसत नाही. तुला परत मागे जावं लागेल ऋषिकेश.
Okay.
क्लोज कर आणि मग नंतर परत.
आधी फुल स्क्रीन करून ओपन कर आणि मग नंतर शेअर कर.
आता आलंय सर?
नाही.
जर तुम्ही आधी प्रेझेंटेशन फुल स्क्रीन करा, आधी शेअरिंग बंद करा.
हां.
शेअरिंग बंद केलं तुम्ही?
Yes.
आता प्रेझेंटेशन फुल स्क्रीन करा.
Okay.
विदाउट शेअरिंग.
हां.
झालं फुल स्क्रीन? नाव शेअर स्क्रीन वर क्लिक करा सर. नाव क्लिक ऑन द शेअर स्क्रीन बटन आणि ते करताना जी फुल स्क्रीनची तुमची विंडो आहे तिला सिलेक्ट करा.
दोन मिनिटं गेले तुझे ऋषिकेश. ऋषिकेश मॅडम तुमच्या एंडने करता का? नाही.
आता फुल स्क्रीन नाही आहे सर.
नाही फुल
स्लाइड शो
स्क्रीन.
करा सर. स्लाइड शोच्या बटनवर क्लिक करा. जस्ट क्लिक ऑन द स्लाइड शो बटन. वरती मेन्यू मध्ये आहे बघा. इट इज ऑन द मेन्यू. स्लाइड शो.
आता आलंय मॅडम?
नाही सर.
लेफ्ट साइडच्या वर दिलेला आहे स्लाइड शो फ्रॉम बिगिनिंग.
सर वरती होम, इन्सर्ट, डिझाईन, एनिमेशन्स,
लेफ्ट साइडला.
स्लाइड शो. नेहा मॅम, आर यू शेअरिंग?
ऋषिकेश होतंय का? ऋषिकेश.
Dr. Rishikesh, are you sharing or should I?
Next speaker we can take.
Yes. Done.
Done. Okay.
Please
Good.
start, Rishikesh.
Good.
Yes, it's full screen now. Yes. Kindly start. Thank you. Dr. Rishikesh, you are mute.
Unmute yourself, Rishikesh.
Yes. Okay. So I will start my presentation. Thanks Maharashtra IAP and Women's Committee for giving me an opportunity to talk about the topic which is very close to my heart. And the topic that is allotted to me is the developmental history. And I will clear that I am not going to speak about the developmental screening or the test, confirmatory test or the intervention part here. So I will start. Yes. So when we talk about the developmental, there are three parts. There is developmental delay, developmental dissociation, developmental deviation, and the developmental regression. Okay. So developmental delay as in development of one or more domains. Okay, two or more domains. And developmental dissociation refers to a discrepancy between the developmental rates of two streams of development, with one stream significantly more delayed. And developmental deviance refers to non-sequential unevenness in achievement of the or more streams of development. And refers to the loss of milestone that were milestone is a characteristic of the neurodegenerative disorder. So what are the aim of the developmental history is to determine the following point: is is it a true developmental delay or not? Is it a true motor delay or cognitive development? Is it a progressive or the static disorder? And also we have to localize the anatomical localization. That is what is the neuroanatomical side. This is the central, peripheral, or the combined system. So first we go to the birth history and ANC and birth history. So pregnancy, during pregnancy, what are the important points that we have to ask is first is the age of the parent, the conception. Increased risk is a risk factor for the Down syndrome, and the history of infertility or use of medications or the fertility technique, and history of hospitalization for any illness, and history of decreased fetal movement. That is important for this, congenital some of the disorders, the amyloidosis and the spinal muscular atrophy also. And we will also have to ask about the history of exposure to the medicines, tobacco, alcohol, and drugs and chemicals that can cause the teratogenic disorders and the fetal alcohol syndrome. And we also have to ask about the illnesses like the fever, exposure to infections like the TORC and the bleeding and the preterm labor, and abnormal results of the prenatal testings or the ultrasounds are also important. Now we will move on to the birth history part. That is, we have to ask about the complications of the labor and the delivery and the neonatal conditions and the complication that exerts a long-term impact on the development. Difficulties with the parturition, including the prolonged labor with the fetal distress, neonatal depression, and the premature delivery, pose varying risks to the immediate and the long-term complication. And the risk of the neurodevelopmental sequelae increases with the decreasing gestation age and the birth weight also. The neonatal complication, including the HIE, hyperbilirubinemia, hypoglycemia, sepsis, meningitis, seizure, IVH, intraventricular hemorrhage, and periventricular leukemia, and the ROP contribute to establish the risk for the adverse developmental outcome. Additional information that we have to ask about the birth history and the ANC history is the history of breech presentation. That is the Prader-Willi syndrome could have a decreased fetal movement and the hypotonia at the birth. Neonatal seizures, inborn errors of metabolism, and the benign neonatal familial convulsion, early myoclonic encephalopathy, incest disorders, and related to this disorders, we have to ask about the neonatal seizure. And also have to the obstructive apnea that can be a presentation or sequelae of achondroplasia or Downs or Treacher-Collins syndrome. Past medical history, there's the medical and the surgical history exposure established and the associated risk of the serious infection, head trauma, seizure disorder, chronic medical and the metabolic condition, history of the acute illnesses and traumatic head injury or the chronic illnesses such as the hypothyroidism can guide us the probable cause and the etiology of the developmental diagnosis. Complicated submucosal cleft palate defect or the cardiac anomaly defect point towards the possible genetic syndrome associated with the midline defect and associated neurodevelopmental disorder. The family history, the 3-generation pedigree chart, maternal and paternal pedigree, and the history of consanguinity. The consanguinity makes the autosomal recessive inheritance more likely. And for the boys with the developmental delay, particularly the motor, that is important to ask about the history, and it is also linked to X-linked disorder, particularly the DMD, and the previous pregnancy outcome, that is miscarriages, stillbirth, neonatal, and the childhood death, and the infertility. Particularly the miscarriages and the stillbirth and the IVR baby can relate it to the autosomal in. So now we will move on to the developmental part. That's what we have to ask about the development of the child. And here is the pictorial depiction of the normal development of the baby, specifically within the first 1 and 2 years of age group. So here we can see how the motor development particularly progresses. Okay, so during the first initial slide, we can see this the flex posture of the newborn or the early infancy is there, and gradually that we know that the cephalocaudal development is there and proximal to distal development is there. So the third picture, that is around 2 to 3 months age, we can see the infant, particularly he's holding his head, holding his weight on the forearm, and during the 4th or 5th picture, he's able to sit with support and without support, and gradually stands with support and without support also. So these are the red flag signs for the gross motor milestone. And if these red flag signs, I mean to say that this is not about the normal development. The normal development progress is different thing, And these are the red flag signs, because we have to say, or we have to take some amount of period, that is 1 to 2 minutes, that is progressive from the normal development, and this is depicted as a red flag sign. So at the age of 9 months, if there is no sitting without support, and at the age of 12 months, no stand with assistant, at the age of 17 months, no, if the child is unable to stand alone, and if at the age of 18 months if he is unable to walk alone, and if at the age of 2 years, if he is unable to walk upstairs without help, and at the age of 4 years, if he is unable to jump. So these are the red flag signs for this gross motor milestone. Now we will move on to the fine motor milestone. So this is somewhat about the normal fine motor development. At the age of 3 months, the grasp reflex disappear. At the age of 4 months, the child tries to grasp the red ring dangling in the front, but may he overshoot. The bidextrous grasp is there. And 5 months, reach it out and the object. 6 months, transfer the object, and 9 to 12 months, immature to mature the pincer grasp. The typical development of the pencil grasp in children, this is also there. So initially the pincer grasp, then the palmar supinate at the age of 12 to 15, digital pronate, quadruped, and the tripod grasp. And these are the red flag signs for the fine motor development. At the age of 5 months, if he is unable to hold the rattle. At the age of 12 months, if there is no pincer grasp. At the age of 20 months, that is around 18, that 1.5 years, if he is unable to remove the socks or the clothes. And at the age of 2 years, if he is unable to scribble. At the age of 3 years, if the child is not able to work out on the toys, and the age of 5 years, if he is not able to draw a simple picture or the gauges figures, we can also track. Then these are the red flag signs for fine motor. Just few slides remaining. Now the third domain is the language domain. We know there are 2 parts, the receptive and the expressive part. This is the normal language development. And at the age of 3 months, cooing and the gurgling started, and at the age of 3 to 4 months, reciprocal cooing is there. At the age of 6 months, babbling, and at the age of 6 to 8 months, from monosyllables to bisyllables, and at the age of 12 to 15 months, the child is able to speak the first word. And the age of 18 months, he knows the 5 to 40 words, but able to speak the 5 to 10 words. 2 years, phrase speech is there. 3 years, sentence formations are there. And at the age of 5 years, he identifies the letter, create the longer sentences. Okay, so these are the red flag signs for the language development. At the age of 1 year, if there is no babbling or the vocal imitation. At the age of 1.5 year, if there is a no use of single word. And at the age of 2 years, if single word vocabulary less than 10 words. At the age of 30 months, that is around 2.5 years, less than 20 word and no 2-word combination. At the age of 3 years, there are if less than 200 words and no telegraphic speech. And at the age of 3.5 years, if there is a no simple sentence formation, then these are the red flag signs for language development. And the last slide. Now we will move on to the personal social domain and the cognitive domain. This is a type of play actually depicted, and this is very important if you consider the autism. That autism, the play is mostly self-absorbed, functional, or the less functionality and sensory motor play is there, and less associative and cooperative play in autism. And this is the red flag signs for the social domain. If at the age of 2 months child no social smile, at the age of 12 months no pointing or waving, and so at the age of 12 months also there is no joyful expression. At the age of 3 years no pretend play, and at the age of 4 years there is the child is not able to respond to his peers. And at the age of 5 years, usually, if the child is unusually withdrawn and the not active, then we have to intervene. And before intervention also we have to ask the history in detail, and then we have to mental disorder. So during the first year of life, motor delay predominate. During the second year of life, fine motor delay predominate. During the third and fourth year of life, language disorder mostly detected. In older preschool years and the elementary school children, developmental coordination disorder, behavioral disorders, and learning difficulties diagnosed in this age. This is a very simple slide. Domain and the underlying developmental disorder, and this is a very easy slide. Mainly, if the developmental delay is mainly in the gross motor domain along with the tone and postural abnormalities, then it is pointing towards the cerebral palsy. If the general intellectual function is delayed along with the social skill and adaptive behavioral function delay, then it points toward the intellectual disability. And if there is a deficit in the social communication and interaction and the restrictive and repetitive behavior along with the sensory issues, then it's a pointer towards the autism. And if then there are few wordings also about the learning disability also. This is dyslexia, dysgraphia, and dyscalculia also. So what are the red flag signs for the IEM? So the family history of IEM or the unexplained neonatal death, consanguinity, IUDR baby or failure to thrive, current episodes of vomiting, ataxia, seizure, and the lethargic coma, and history of being severely symptomatic and needing longer time to recover with the benign illnesses, unusual dietary preferences, regression, and the motor disorder, facial dysmorphism, organomegaly, congenital severe hypotonia, congenital non-facial anomalies, and the sensory defects along with the progressive spinal deformities and neuroimaging abnormalities. These are the red flag signs for the IEM. And there are some pointing history related point that we have to ask. And this also help us towards suggesting that is it central disorder like a cerebral palsy, or is it a peripheral disorder like a SMA or DMD, SMA or like a myasthenia or any other neuromuscular disorder. So what are the history suggesting central causes of developmental delay? Eventful antenatal and the perinatal history, affected hearing, vision, and the cognition, and the colical behavior in early infantile period, along with the feeding problems and the sleep disturbances, features of the encephalopathy and the seizure, and history of the movement disorder. आपल्याला खूप वेळा माहिती पडते की वो cerebral palsy चा मुलगा आहे. सुरुवातीला during period we may not get the tone and the postural abnormalities, but yes, there is a continued crying and the feeding difficulty is there. From around the 3 to 4 months of period, scissoring also. Suggesting of the peripheral causes of developmental delay is alert baby who is not moving with the history of lack of anti-gravity movement along with the diminished TTR points out towards the peripheral etiology of the developmental delay, that is a SMA, and history of myotonia in a short stature mother along with the alopecia with the recurrent abortions points towards the congenital muscular dystrophy, and the fatigability and the diurnal variation in the weakness along with the ophthalmoplegia and ptosis points towards the neuromuscular function disorder like the myasthenia. Thanks, and sorry for the inconvenience caused initially.
Yeah, thank you very much, Rishikesh. I think you have extensively covered about the developmental history, and the most important points to remember are that we always get the antenatal, natal, and postnatal history and NICU history, which is very important for developmental problems. And for that, only 6 areas are very important where we have to take the history in case of gross motor development, fine motor development, then mental development, social development, expressive language, and receptive language. So these 6 areas is the progress card for the first 6 years of the life, and that is very important to remember while taking the history. Thank you, Rishikesh. You have explained it very nicely. Thank you.
Thank you, Dr. Rishikesh Ghator, sir, and thank you, Tambori, sir. Now I welcome our last speaker, Dr. Amol Mahajan, sir, who is member of Pune IAP. Sir will be presenting topic on umbilical sepsis. Sir is owner and managing director at Aadhar Multi-Speciality Hospital, Hadapsar, Pune, and is joint secretary of Pune IAP. Please, sir, you can start with your lecture.
Thank you very much for a great introduction. And I'm really thankful for MAHA-AP for giving me such opportunity. I will start my slides. Umbilical sepsis is very well known as omphalitis. In my topic, I will cover introduction, epidemiology, etiology, pathophysiology, clinical features, management, physical examination, investigation, treatment part, prevention, complication, prognosis, and disease. Introduction. Umbilitis is an infection of the umbilical stem. It typically presents as a superficial cellulitis, that is, as a red flare in the periumbilical skin. the cellulitis may progress rapidly with potentially serious consequences, including systemic diseases. Omphallitis is predominantly a disease of the neonates. What is the epidemiology? Internationally, overall incidence is less than 1%, and incidence varies from 0.2 to 0.7% in developed countries. Omphallitis has become rare in industrialized countries. It still remains a common cause of neonatal mortality in the less developed countries. Incidence is higher in hospitalized preterm infants than in full-term infants. Episodes of omphallitis are reported and usually are sporadic. Rarely, epidemics can occur due to a group A streptococcus. There are no sex predilection has been reported, although males have a worse prognosis than female. Introduction of aseptic cord care has greatly reduced the occurrence. What are the etiological features? Approximately 85% of cases are polymicrobial in origin. Aerobic bacteria present in 85% of infection, dominated by Staph aureus, group A streptococcus, E. coli, Klebsiella, and Proteus mirabilis. Recent studies have highlighted gram-negative organisms also are the causes. Change in etiology may be caused by prophylactic umbilical cord care using anti-staphylococcal agents. A third of the patients have infection caused by anaerobes, predominantly Bacteroides fragilis and Clostridium. Pseudomonas species have been implicated in particularly rapid or invasive disease. What is the pathophysiology? The umbilical cord represents a unique and universally acquired wound in which devitalized tissues provides a medium that support of bacterial growth. Normally, the cord area is colonized with potential bacterial pathogen during or soon after birth. These bacteria have the potential to invade the umbilical stem, leading to omphallitis. The factors that cause colonization to progress to infection are not well understood. Some proposed factors are: it is a polymicrobial infection caused by a mixture of aerobic and anaerobic organisms. Associated risk factors include the low birth weight, prior umbilical catheterization, septic delivery, premature rupture of membrane, non-sterile delivery, or maternal infection, and prolonged rupture of membrane. Omphallitis occasionally manifests from an underlying immunologic disorders. These infants are subsequently diagnosed with leukocyte adhesion deficiency, a rare disorder with AR pattern of inheritance. These infants present with the F2G, then leukocytosis, delayed separation of the umbilical cord, and recurrent infection. Omphallitis may also be the initial manifestation of neutropenia in neonates. Affected infants present with cutaneous infections, sepsis, as well as pneumonia. Rarely, an anatomic abnormality may be present, such as patent urachus or patent omphalomesenteric duct. What are the clinical features? In term infant, the mean age at onset is 5 to 9 days, and in preterm infant, the age is less in 3 to 5 days. Patient present with redness and swelling, that is cellulitis around the umbilicus, purulent or malodorous discharge from the umbilicus. Baby is highly irritable. The cellulitis is rapidly progressive and may lead to necrotizing fasciitis. Necrotizing fasciitis is characterized by abdominal distension, fever, and tachycardia. Despite the illness, most of the neonates present have good appetite and continue to suck. What is the management point of view? Mostly the detailed history of pregnancy, labor, and delivery and neonatal course is important. Physical examination signs vary from with extended disease like local signs. There is purulent or malodorous discharge from umbilical stem, periumbilical erythema is there, edema, tenderness, as well as extensive local disease such as fasciitis, myonecrosis. It shows both infection, aerobic and anaerobic organisms. Periumbilical ecchymosis, crepitus, bully, or progression of cellulitis despite of antimicrobial therapy. In systemic diseases, non-specific and include disturbances of thermoregulation or evidence of dysfunction, like disturbance of thermoregulation, fever more than 38 degrees centigrade. In CVS, there will be PR is 180, hypotension is there, or delayed capillary refill time. Respiratory disturbances such as apnea, tachypnea, grunting, flaring alenesia, intercostal retractions. In GI, there will be rigid and distended abdominal or absent bowel sound. Cutaneous abnormalities like jaundice, petechia, cyanosis, and in neurologic abnormalities like irritability, lethargy, weak sucking, hypotonia, hypertonia. These are the pictures with extensive local disease and systemic disease. This is also pictures, typical pictures. What are the investigation points? This is mostly the clinical picture of omphallitis is sufficient to characterize and to diagnose the disease. determining whether associated complications are present, such as systemic infection, necrotizing fasciitis, myonecrosis, or portal thrombosis is very important. What are the lab studies? Obtain specimen from umbilical infection for gram stain and culture for aerobic and anaerobic organism. Blood culture is important. Then PCV, WBC, platelet film appearance like neutrophilia or neutropenia may be present. Acute thrombocytopenia may be present. Hypoglycemia is there. Metabolic acidosis is seen. And other non-specific lab tests like C-reactive protein, ESR, limulus lysate test which detect endotoxins. Imaging studies rarely required. Abdominal radiographs may reveal intra-abdominal wall gas, and CT scan of the abdomen may determine the presence and extent of muscle involvement in complicated cases. Sometimes LP may be warranted in infants in whom sepsis is suspected. Then anterior abdominal wall biopsy, it shows histological findings may reveal necrotizing fasciitis, which is an acute inflammatory infiltrate found in subcutaneous fat and connective tissue, or myonecrosis, which is an acute inflammatory process surrounding muscle bundles, many of which are no longer viable. Treatment point of view, mostly the medical care is important, and after that surgical care is required. And antimicrobial therapy, parental antimicrobial coverage for gram positive as well as gram negative organisms is most important. Staphylococcal, penicillin and aminoglycoside is recommended. Anaerobic coverage is important for all patients. In our center, cloxacillin or plus gentamicin plus flagyl is we can use, or cephalosporin plus gentamicin with flagyl from the usual antimicrobial combination. In most of our patient organisms, culture are sensitive to virtually all match antibiotics. Expect erythema of the umbilical stump to improve within 12 to 24 hours after the initiation of antimicrobial therapy, not usually the case here. Sometimes steroid is used for as an anti-inflammatory effect. It affects on immunologic reaction. We can use dexamethasone intravenously at a dose of 0.5 milligram per kg dose 6 hourly. Supportive care is also important. Administer fluid for hypotension. Blood products can be given. Packed red blood cells. Plasma transfusion in the center has helped to prolong life by few hours. But then monitor and manage metabolic abnormalities. Diet, parenteral nutrition is required in infant. Then enteral feeding is also used. Monitor patients for progression of disease and provide ventilatory assistance or supplemental oxygen for hypoxemia cases and apnea cases. Surgical cases may require.
Amol,
Yes, sir.
Where do you have references for all this? You are saying dexamethasone 0.5 milligram per kg.
Sir, sometimes it may require in complicated.
Did you share your presentation with Suchit or somebody?
Yes, sir. Suchit, sir,
Suchit, did you go through this?
Yeah, I've seen the presentation and
No, that's see, we are talking on a state forum, and very wrong messages or this should not go. Where do you have reference of 0.5 milligram per kg? Where do you have reference of flagyl?
Sir, I have checked it on some topics previously.
No, you cannot mention steroid. If at all you want to mention, the dose is not like this. 0.5 milligram is per kg is a elephantine dose.
Okay, sir.
And
I will
where did you get the reference of flagyl with this thing?
These are all I have searched in previous presentations and all the things.
Yes, sorry to interrupt you, but this is not, I think, very academic. But please go ahead. Whatever Suchit will correct this, but I thought this should not be a message which should be going to the pediatricians who are attending this or delegates.
Okay, sir. Okay, sir. Surgical care, some early surgery may be life-saving. It involves early and complete surgical debridement, excision of pre or peritoneal tissues, umbilicus vessels, critically important in eradication of infection. Most of our patients, third to fourth day of presentations. Prevention, good antenatal care, supervised aseptic delivery is required. cord care with antimicrobial agents to decrease the bacterial colonization, like methyl lated spirit. We are generally using povidone iodine, sulfadazine, and bacitracin ointment. Discourage harmful practices like application of cow dung or hot water fermentation to the cord. Complications, sometimes there will be necrotizing fasciitis, myonecrosis, septic embolization, septicemia, portal vein thrombosis, and prognosis for most of the infants is variable. In most cases, prognosis is poor if complicated cases are there in less developed countries. And what are the DDs? That is anterior abdominal wall cellulitis, neonatal septicemia, burns, urachal cyst with second degree bacterial infections. Thank you very much, sir. Over to you, Suchit, sir.
Yes, thank you, Amol. Actually, as Ramakant has said rightly, we have to have some references regarding that. But only thing is that what message we can give regarding umbilical sepsis is that prevention is very important. That is the first important point for umbilical sepsis. And then at what stage you are actually examining the patient is very important. So according to that, whatever the whether it is a localized infection or it is a septicemia, according to that we have to go further. And I think these 2-3 objectionable points are there, and we should give references for that. Okay.
Yes, sir. Yes. Thank you, sir.
So I think all of us, all speakers have presented, and they have tried their best. Their first presentation is there. Many faculty actually they have presented first time. So we must encourage them and keep them encouraging so that they can actually present more better. Because these slides many times what I have seen that they have only writing material like 1, 2, 3, 4, 5 everything, but only, they should have less number of actually lines on the slides, and pictorial should be more to explain the your presentation, and it should be actually self-explanatory for the delegates to attend, so that they can read that and they can come to know the not theoretical part, but all practical oriented part. And I must congratulate all of them. Thank you very much.
Thank you. Thank you, Amol Mahajan sir. Thank you, Tamboli sir. Now I think I'll pass over to Neha ma'am because we are waiting for the question answer session.
Thank you, Dr. Sonal. I cannot see any question in the chat box. If anyone wants to ask any question, they can. Ramakant sir, do you want to?
It was a wonderful session, very nice presentation, and I appreciate everybody finished in time, and very nice expert comments from Dr. Suchit Tamboli sir. Presentations were really informative and good presentation, and I really congratulate the Tuesday Tech organizers, Sonali, Neha, and all the team. In umbilical cord, what is current concept is just keep it dry. Keep it dry. Don't apply any powder. And second most important common problem everybody of us has faced is an umbilical granuloma. So we should make it a point that once the cord has fallen, whatever antibiotic powder or whatever has been prescribed, it should be stopped at that moment. Because parents keep it on spraying there or applying something on that or applying some oil or ointment, and this granuloma goes on up to 3 months and 6 months also. So the dictum is keep it dry. Do not apply anything. That is most important. And in 33 years, I have seen only one case of urachus. So the smell of urine is only important for this thing. Wonderful presentation on DSD. Very good deliberation. I am very well informed by this topic, so I didn't have any questions on this.
Thank you, sir.
Suchit sir,
Yes.
so for how many means till what age of this thing in newborns we should wait for this umbilical granuloma?
Actually,
When to refer to surgeon?
the most important thing is that means actually umbilical granuloma. It goes off as he has said, but my experience, one of the experience I can say that की umbilical granuloma आपण एक काळ्या मिठाचा जो खडा असतो तो लावल्यानंतर त्याच्या 5 दिवसात ते पूर्ण जातं असं माझे जवळजवळ 90% पेशंटचा अनुभव आहे, 95% पेशंटचा अनुभव आहे. म्हणजे रमाकांत त्याच्याशी ऍग्री होतो की माहिती नाही मला, पण त्याचा नक्कीच खूप चांगला उपयोग होतो असा माझा अनुभव आहे. आणि त्याच्यानंतर जे काही 2-5% असतात ते बऱ्याचदा स्वतःहून बरे होतात. 1-2% असतात की ज्यांना आपल्याला रेफर करायला लागतं आणि ते 1% पेक्षा पण कमी असतात की ज्याचे आपण 3 महिन्याच्या नंतर रेफर करू शकतो.
I think here we do not need surgical referral unless until you are suspecting. That's what I told. In 33 years, only one virus was there, which I had referred. Keeping it dry. What Suchit has said, that is only thing. This salt, if it is a dry, it acts as a hygroscopic. It makes the cord dry.
Yes.
So even if we say it is a sodium chloride cautery, it is not a cautery actually. So these are if you keep it dry. So sometimes we have to tell that what I practically and most of the neonatologists 10 days do not do anything on this. Do not put anything. 95%, 98% become all right by that. Even after 10 days, if it doesn't dry, then you can try this sodium chloride cautery or dry salt. But make it point that it should be dry. If it is in monsoon season, आपण जे सादळलेलं मीठ म्हणतो तर त्याचा काय उपयोग नाही. The basic purpose of keeping it dry becomes nullified. So we have to make it dry. Even in monsoon season, warm it, let it cool down, it becomes dry, and then every time while breastfeeding, you can put it in. So whatever burning sensation is there, because of while breastfeeding, it is negated and child does not cry more. So this is the principle behind this, so applying sodium chloride or salt, common salt for umbilical granuloma. So for umbilical granuloma, if you make it a point or ask grandmother or mother, if there is a smell of urine, then and then only you go for sonography, and urachus is most of the time detected.
Yes, sir. So today we had an excellent session of Tuesday Take with good topics, good audience, and excellent expert and speakers. So now for the vote of thanks, I would like to thank our MAHA-AP President Dr. Ramakant Patil sir and our Secretary General Dr. Amol Pawar sir for giving us their support and MAHA-AP platform. I would also like to thank Dr. Suchit Tamboli sir for accepting our invitation for being the expert for today's Tuesday Take program. Sir, your guidance and expertise comments were very helpful and informative. I thank Maharashtra Medical Council and our MMC observer of today, Dr. Shirish Deshpande sir, for giving us 1 MMC point. Thank you, sir, for joining us. I would thank all the 5 speakers of today for preparing and delivering their topics fantastically. Dr. Sheetal, Dr. Ujjwala, Dr. Anurag, Dr. Rishikesh, and Dr. Amol. Really, you all were excellent today. Also would like to thank our Women's Committee Chairperson, Dr. Sonali Shirvate ma'am, our convener, Dr. Manjusha Sherkar ma'am, as well as other members of Women's Committee for helping in organizing today's program. I would also like to appreciate and thank Dr. Sonal Shinde to be my partner in moderating today's program. Thank you all the EBs and OPs of MAHA-AP for their support and joining us today. Thank you, Pallavi ma'am, for solving all the technical issues. Last but not least, all the attendees on Zoom as well as YouTube live for joining us today. Requesting all to please join next Tuesday Take on 18th April, 9 p.m. Thank you so much. Good night.
Thank you.
Madam, meeting end kara. Recording
Yes, sir.
stop.
Yes, sir.